Bora experience once again. I was here, I think a year ago, a little over a year ago, possibly, and I'm back again this evening to share with you. And the last time I was here, it was quite a beautiful session. I thoroughly enjoyed it, and I believe that we probably could have gone hours, but but we had shortened it for the sake of the elect. And so this evening we will be presenting on on women's health. And I want to thank you, Minister Bonzo, for having invited me. And I also want to greet all the participants who are online this evening, those who are from Jamaica, those who are abroad. I want to welcome you and thank you for having joined this evening for this presentation that will be done. All right. So Minister Bonzo spoke about the gave a little introduction about women's health. And, as I prepare to share my screen, I'm gonna just ask for the privilege to do so, so that I'm able to share those slides that I have, that you may be able to follow me in the presentation, because an important part of teaching is also seeing. So once you're able to see what we're talking about, then it makes it a little bit better to understand. All right, so let me put this up. All right, and I just want to check that you're actually seeing my screen. It's not
Yes, we
that.
are, though. We are
Yes,
seeing
yeah.
In that one, okay. All right. It's not that. It's this one. Yeah, great. All right. I'm just trying now to maneuver to my slideshow. Okay, great. All right, so we have quite a bit to talk about this evening, but I promise you that by the end of it, we will also leave space for questions. And so I'll get through the presentation as quickly as possible, highlighting the main points so that we can have that interaction at the end, that clarification at the end. Because this is not just a presentation per se, but it's possibly also and consultation, so to speak. All right. But so you have questions and queries you can ask, and I'll be able to address them as best as I possibly can. All right. So we're talking about women's health, and women's health include a lot of things. There are a lot of things that concern women. And as we know, health is not just the absence of disease, but it's basically the well-being of the individual overall. We're talking about biological, psychological, spiritual, and social. The last presentation we touched on menopause and its effect on the woman and also on the family. And this evening we'll be touching on some various four particular can type of cancers as it relates to women's health. These are the ones that are basically affecting a significant amount of our women in our population. And it's this evening, I believe, is an opportune moment for us to highlight these as we focus on women's health. So I know a lot of individuals, they don't like cancer, they don't like to hear about cancer, but this thing is just basically a reality, and we just have to face it and see how best we can put measures in place to mitigate against its effect and also even to prevent its occurrence in our life. So cancer is the uncontrolled growth of abnormal cells in the body. So basically, every day, cells in your body are growing, and there might be a cell that goes rogue. It starts to develop abnormally. We're going out of control. Every day we have these cells, they start to develop in our bodies, and our body, generally speaking, picks them up and destroy them before they can ever reach any further. So therefore, whenever it is that a cancer develops in the body, it's because it has escaped the mechanism of the body to detect it. Some cells, when they start to go rogue and develop into cancer, they actually commit a suicide. They self-destruct so as to prevent any abnormal growth. So once they realize that something is going wrong, then they self-destruct. And if it is that that mechanism fails, then it's that cell sends off a signal to the Renato Adams that is circulating in the body, and it goes around and it finds the cell and it destroys it wherever it is, right? And so whenever a cancer occurs, it's mainly because this has escaped the body's mechanism of detecting it. And there are numerous reasons why these things can go undetected, right? And some of them will be highlighted as we touch on the various cancers. Now, as had mentioned before, if you normally have what we call the cell division. You have the normal cells. If a cell is damaged, right? In other words, it's going towards a cancer, tending towards a cancer, then it destroys itself. But if it misses it, then it just continues. The bottom one there that you see with purple, right? It continues to divide and multiplies, and then that's where you have the cancer. So there are three main characteristics of cancer. Its abnormality, its uncontrollability, and its invasiveness. So it's abnormal, as I had mentioned before. It's not normal. It doesn't fit in with the rest of the cells. It is uncontrollable. It is not under the control of the body anymore. It's doing its own thing. And not only is it abnormal, not only is it uncontrollable, but it also invades other spaces, right? So that's when you start to hear about metastasis or cancer spread, right? So it doesn't stay where it is, it moves, right? Because this thing wants to take over the entire body, right? Just like sin wants to take full control. It just doesn't stay in one corner, right? As the Bible says, a little leaveneth the whole lump, right? And this is how cancer work. It doesn't just stay one place, it spreads to other places. And therefore, it is important to catch it before it starts to spread. Because once it starts to spread, then the prognosis is not good. In other words, the chance of survival start to decrease significantly when it starts to spread. Now, if you look at this is the predicted global cancer cases from 2012 to 2035. And if you look at it, you'll realize that right across the world, there is an uptick, right? There's a steady rise in cancers, right? And they say up to the year 20, they say the year 2050, by the time we reach the year 2050, cancer possibly will be the leading cause of death across the world. No, it's things like heart attack and strokes and all of those things. But in another 25 years or so, it is predicted or estimated that cancer could well be the leading cause of death across the world for all age groups, right? Possibly, right? And so when you think about things like this, it's very important that we realize where the world is heading, and we try to be the anomaly, so to speak, not to head where the world is heading, but to be different in the sense that our lifestyle will help us to prevent some of these things. Or even if it's not to prevent it, but to catch it when it's very early so that it does not have those deleterious effects on us. No, so cancers, so we're going to delve into some of the cancers that most frequently affect the Jamaican women, right? So we look at this graph here and you'll see here presented some cancers, right? And if you notice, breast cancer takes up the vast majority, followed by other type of cancers. So they group some other cancer, whether it be skin cancer, throat cancer, all sorts of other cancers, right? So if you notice the big ones, breast cancer, cancer of the uterus, cancer of the cervix, right? So those are some of the big ones. And then now you have things like colorectal cancer, that is cancer of the tripe or the gastrointestinal tract, and also lung cancer. Now, if you look at this graph here, it talks, it's a comparison of the cervical cancer incidence to other cancers in women of all ages in Jamaica. And if you notice, breast cancer is way out there, but notice where cervical cancer is. It's high up there as well, right? And so you notice breast cancer and cervical cancer are two of the leading causes of death. And if you notice in the top four or top five, or in the top 10, you have breast cancer, you have, and these are cancers that primarily affect women, right? That I'm going to mention of breast cancer, cervical cancer, corpus uteri cancer or endometrial cancer, and ovarian cancer, all of those. So all of these cancers that affect women, all of them are in the top 10 of the incidence, right, of cancer in Jamaica, right? If you look at the comparison for age-specific cancer to age-specific incidence compared to other cancers, if you notice, again, breast cancer, cervical cancer, ovarian cancer, right, jump out at you again. Now, if you look, and this now, there are some other statistics that they had, but the one for cervical cancer to me seem a little bit more alarming than the rest. If you notice, this is the age standardized incidence rates of cervical cancer. In other words, after having justified for age, right, they compare the different countries, right? Look at Jamaica. Look at Jamaica compared to Haiti. Haiti that we think would probably have it much, much higher than us, right? Haiti is 17.1, Dumrep 17.1, Barbados 15.5, Trinidad and Tobago, Jamaica 28.4 in the Caribbean, the highest in the Caribbean, right? And so you see why this presentation this evening is important, because we are leading the Caribbean in terms of the rates of cervical cancer. And this is not something good, something to be proud about or anything like that, because a significant amount of women die, at least 200 women die every year from cervical cancer here in Jamaica, right? And it is worsening. It's getting worse each year because we're detecting more and all these things. You understand? So it's serious that Jamaica is way out there. It's not like Haiti is at 17 and we're at 20, right? We're clear 11.3 points greater than any other Caribbean country, right? Including Haiti and the Dominican Republic. Those are the ones that come closest to us, right? So that's one race that we don't want to be winning. Right. And same thing again, if we continue the comparison of cervical cancer mortality rate to other cancers, if you realize cervical, a lot of women are dying from breast cancer, right, which need not be so. A lot of women are dying from cervical cancer, which need not be so. Not a single woman needs to die from cervical cancer. While you probably can understand ovarian cancer and the lung cancer and the other cancers, cervical cancer is one cancer that no woman should die from, because there's adequate screening for it, and once it's detected, it is one of the only cancer that you can think about that it gives a warning sign or signal before it develops. So when we do the pap smear, for example, we see the tendency where it's going, and we can do the necessary intervention to prevent cancer Most other cancers, they just present as cancer, and that's it. There's nothing you can do about it. But cervical cancer, we see it before it reaches cancer, long before it reaches cancer. We see it. And, or it can be seen long before it reaches cancer. Right. So no, you realize how serious this thing is. And in fact, I was in a national meeting the other day, and they were actually reporting that Clarendon in particular has one of the lowest uptake in terms of screening for cervical cancer, right? Compared to the other parishes, right? And we have a lot of women in Clarendon who are, diagnosed with cervical cancer and dying of cervical cancer. And it has of all the parishes, Clarendon has one of the lowest uptake in terms of screening for cervical cancer using the pap smear. All right. So that being said, enough of the statistics, right? So we'll talk a little bit now about breast. Right, the first one that we delve into is breast cancer, because as you would have seen from the presentation, it's one of the leading causes of death for women. Now, so breast cancer is cancer of the breast, right? And so some of the risk factors for breast cancer. So I broke it down into risk factors. So if you read any textbook, if you go on the internet, they'll talk about possibly modifiable and non-modifiable risk factors. So modifiable risk factors mean those that you can change. Non-modifiable means those that you cannot change. So in the case of breast cancer, we have um, those that you cannot change. So I broke it down like that, and we look at that those that you can change afterwards. So getting older, you can't really change getting older. You can't change that. Every day we get older. In fact, right at this moment in time, it's the youngest that you'll ever be as of now, right? You'll never be younger than how you are now, right? So you have to celebrate the youthfulness now, because never again will you be this young, right? So getting older is, I mean, it's inevitable. Genetic mutations, we cannot control these things. They happen in us based on the diet that we have, based on our exposure to certain substances, certain chemicals, based on stress, working in a lot of these things. So you have genetic mutations, you have reproductive history. So, for example, women who have not had any children at all, they're at an increased risk of breast cancer, right? Say, have a woman, a female, for example, she's 60 years old, she has never had any children. That's not something that she can change, right, in terms of her reproductive history. So therefore, she won't be able to modify that risk. Having dense breasts. So clearly, the bigger the breast, the more likely it is that you'll have breast cancer. Because if you have more tissue, then there's a greater chance that something might go abnormal in those tissue. Now, I just want to pause here to say that sometimes um, men, men actually can get breast cancer. And when men get breast cancer, it's generally worse than when a female gets it. And the reason for this is that females have bigger breasts. Well, females actually have breasts. Men don't really have breasts, right? So females have dense breasts. And so when the lumps start to develop, for example, it has the breast tissue to cushion it, so to speak. So it doesn't spread easily, as opposed, so it has to get to a reasonable size for it to start to spread and go to other areas. For males, no, we don't have dense breasts, right? We don't have breasts. And so once a lump cancer start to develop, it almost start to spread immediately. And therefore, it is worse in men than it is in women in terms of everything. It's aggressiveness, it's mortality than in women. But if you realize in our society as well, it's and why I mention men here is that if you realize a lot of men now actually have breasts, right? This it's a state, it's a thing that is called gynecomastia. I'm not sure if you've ever heard of it, but gyneco, as you know, gyne, mastia has to do with breast. So they're developing female sort of breasts. So what is happening in our males, in the male population, not just in Jamaica, but across the world, is that us as males, we're putting on weight, we're getting fatter, right? And when we are fatter, the extra fat that you put on, it makes estrogen. That is a female hormone, estrogen. And when the estrogen is produced, the little can I call it titty? The little titties that we have, right? Or the little, however you want to call it, they start to grow under the influence of the excess estrogen that is now being produced in the male body as a result of the fat. So if you notice some men who have on weight, if you look at them, they also have breast-like things on their chest, right? It's not quite breast, but it is breast-like, right? And if they're fat enough, it actually will start to look like breast because the extra estrogen that is being produced in the body, in the fatty tissue of the body, it starts to exert its effect on the breast tissue that is in the chest, on the nipples there, and they start to grow. The same thing happen when little girls are growing. If you realize a little girl, when she is little, 5, 6, 7, her chest is flat, right? Flat as an iron board. But as soon as she starts to get the influence of estrogen, you notice the breasts, they start to get bigger, right? And that is under the influence of estrogen. Before, the chest was flat, just like males. When we're slim, the chest is totally flat. But as soon as we start to put on a little fat, the breasts, they start to get bigger under the influence of estrogen, right? So just wanted to insert that there as we talk about breast cancer. It's not only limited to females, also males. So I want to encourage males to check the breast as well if breast is there, right? And be alert to anything going on there, especially when you start to put on weight. So other risk factors that can change are personal history of breast cancer or certain non-cancerous breast disease. So once a person has had a history of breast, it can't really change that if they had a history of breast cancer. If they have a family history of breast cancer, ovarian cancer, it can't change that. That's something that runs in the family, right? So these are things that they can't modify. Previous treatment using radiation. So if they were exposed to radiotherapy for whatever reason, right, they were probably treating some other cancer that increases the risk. Women who took the drug diethylstilbestrol. So this was a drug that was being given I think in 1970s and 80s, mothers would have taken it. So if they were pregnant at that time and the child was exposed to it in utero, as in when the child was in the womb, it increases the risk of breast cancer. This is something that is not modifiable. Now, as it relates to things that can change now, right? Not being physical, so physical inactivity or sedentarism, that's a risk factor for breast cancer. So the more inactive we are, or the less active we are, then that increases the risk of us getting breast cancer. Not only breast cancer, but other cancer. And as I spoke about being overweight or obese after menopause, right? And being overweight is both for males and females, and especially so after. So being overweight or obese before and after menopause is actually important because these are things that can be changed. Taking hormones, there are different women who are taking, for example, hormone replacement therapy, even though most studies have shown that they are harmless, right? There is also a very slight risk, increased risk of some cancers in women who are taking hormone replacement therapy. Reproductive history, that can be changed, right? If you're still 32 and you don't have any children, you can still get pregnant, right? As opposed to if you were 60, right? And drinking alcohol, that has been shown to increase, and not only alcohol, but eating processed food. If you have a diet that is rich in processed food, then that increases the risk of breast cancer. And processed food would mean those, and we're talking about ultra processed food now. So once it comes out of a bag or a tin or anything like that, it's likely that it went to some amount of processing. Now, clearly, some food are more processed than others. So, for example, if you're going to eat a pancake or a cupcake or something like that, that is processed, highly processed, cornflakes, ultra processed, um, corned beef, ultra processed, donut, ultra processed. So you kind of have an understanding what I'm talking about when I say processed food, right? These are things that they are not present like that in their natural form, right? And so if these are things that we can actually change. Now, what are some of the symptoms of breast cancer? And every time I do a presentation like this, I can never remember. I think that that lady scarred me for the rest of my life. And I was in medical school. I was just in, I think I was in third year or second year of medical school. So we're just starting our clinical rotations. And I remember this lady in Cuba. And when I was examining her, taking her history, find out what is going on, and then I was going to examine her now, and I felt a lump in her breast that was as big as my fist. And so I asked her if she felt it, if she knew that there was a lump there, and she said yes. So I said, how long now you knew that there was a lump there? And she said she has known that it was there for a little while. So I say, all right, how long now? Give me and she said, from it probably was as small as a fingernail or something like that. She felt it, right? But she was afraid. And then she just watched this thing just growing and growing and growing until it was as big as a fist, right? Now, clearly by that time, this had spread, gone everywhere in her body. And so, clearly it was just a matter of what we call palliative care now, so to speak, right? Palliative means that we're just trying to treat the symptoms that she's having because there's no need doing any significant intervention because the thing had spread, gone to bone and to brain and to lungs and to air all over the body it was. So there was nothing that we could do. And I always remember this patient because I mean, it was the first time. I guess that's why I remember it, because it was the first time I was experiencing anything like this. Seeing somebody in that state and knowing that this person is going to die, unless it is that the Lord Himself would have intervened and miraculously just got rid of all those cancerous cells. And she did die not too long after. Right? So some of the symptoms of breast cancer, the nipple turning inward. So the nipple was pointed. So you have some women who naturally they have what we call inverted nipples. So some women they have it everted, means it's pointing out. Some women naturally have inverted nipple, means that it is pointing in, right? Now, if the nipple was naturally everted, as in it is pointing out, and then now it's pointing in, it's possible that there could be cancer developing under it, and the cancer is what is pulling it under, right? So if naturally the breasts, the nipples were pointing out and they're now pointing in, that's a cause of concern. If there is any bloody discharge from the nipple or any discharge at all from the nipple, that's a cause of concern, right? If there is any lump in the underarm area, right, that could also be a sign that there is some cancer, because the breast extends to the axilla, the armpit, the tail of Spence, we call it. It goes under the armpit, right? If there's swelling all over the breast, so the breast just gets swollen, right? And I'm talking about the monthly, because monthly, the breasts, they tend to get a little bigger based on where you are in the cycle. So if you're ovulating, the breasts get a little more plump, the face, the lips, the cheeks, they get a little bit more plump because of ovulation and the egg is being released, right? Asking for fertilization. So, all of those changes happen in the body. But outside of that, any swelling of the breast is not normal. Sometimes it can just be a skin irritation. Some patients who come, They tell us that it's just this city area here, it's just always scratching, always itching, always, when you go and examine, you actually feel that there's a lump that is underneath it. They were just feeling a scratch and thought that it was just, but and that is why it's good to ask questions, your patient come ask some questions, and before you know it, they tell you what it is that you need to hear, give you a clue that is pointing you to where, right? Sometimes it can just be pain in the breast or nipple pain, right? And that could be a sign. Sometimes you have dimpling of the skin. So the skin starts to look almost like orange peel, right? So, orange peel, it has those little dents in it. Like sometimes we peel in the orange, has some dent in it at the top, right? So it can look like that. You can have a swelling of a part of the breast or of the whole of the breast, as I had mentioned before, right? So it's very important to know these things. And if you see any of these signs, then you know that you need to go to your doctor quickly and have yourself being evaluated. Now, because breast cancer is so prevalent, we tend to want to start screen early. So for the most part, here in Jamaica, we start to screen from about age 40, 45. The Ministry of Health, I think the current recommendation we have is to start screening at about age 40 because of the high prevalence of breast cancer in Jamaica. In other countries, they actually start at 45. But because it is so aggressive in our women and the prognosis is so poor in our women, we tend not to start at 45. We tend to start a little bit earlier, and we tend to start much earlier if the patient, right, if the female has a strong family history. If she has a strong family history, then you're not going to start at 40. So for example, say if her mother, or say a auntie, first degree auntie, a sister, or something like that, first degree relative, got cancer when they were 35. You're not going to wait until 40 to start screen her for breast cancer, because the youngest person in her family who developed it at 35. So you can't wait. So in other words, we also individualize the care as well. All right. So in that case, we can look at it case by case in some instances. So if a woman has a family history of cancers and they develop cancers early in life before age 40, then you start screening before age 40, right? Because she's at an increased risk compared to the rest of the population. All right. No, as it relates to so every time, for example, I have a patient in office, I always take the opportunity to examine the breast. Even if it is that they came for a pap smear, the breast must be examined. You cannot come to a gynecologist and um say for example, God forbid, you go to another doctor and they now discover that you have a breast lump. I just saw a gynecologist last week. That is not supposed to happen, right? If anybody should find out that there's a lump, not that I want to find any lump at all. I would mind not finding a lump at all, right? But it is important. So what they actually recommend is that um twice so every woman must do their self breast examination monthly, whether or not they are seeing their menses or not. So for the women who are seeing their menses, right, they're still in the reproductive age, you do it before the period starts and after the period ends, just to see if there's any changes in anything that you feel, right? And you do that every month. And for those who are postmenopausal, in other words, they're not seeing any menses, you choose a day of the month, and every month you do it that day. So, for example, you may choose, say that on the first of every month, I'm going to do my breast examination. And you just let the first of every month be the time that you do it's easier to track that way rather than just do it in some random dates, right? So if you're not seeing your menses, I would recommend that you do your self breast examination monthly on a particular day that you choose, right? And sometimes it might be better to choose the first of the month, the first day of the month or the last day of the month, right? But sometimes it kind of tricky using the last day because not every month has a 31st, right? So, but every month has a first. So it might be easier to say the first of every month if you are menopausal, right? So every month, your breast must be checked by you. And then now, twice a year, it is recommended that you allow your doctor to check your breast as well, just to ensure that you're not missing anything, and I just put something out there as well for the kings who are online. Ensure that you check your wife's breast as well. It is very, very important that you do so, right? You have the permission to check your wife's breast. I remember a patient who she wasn't the one who discovered the lump. It was actually her husband who discovered the lump, right? He was the one who discovered it. She was examining her breast and she never felt anything at all, right? And they were there fooling around and he felt the lump and he asked her if she never felt it and she said, no, I never felt anything. And he was putting her hand where he felt it. And that was when she started to feel it. They went to the doctor and they did their checks and everything and found out that it was actually a cancer. And she went and did her her mastectomy, removed the breast, and she's totally fine now. This is like probably 10, 15 years after surgery. So I want to encourage the kings, right? It's your opportunity to to do some doctor work, right? Check your wife's breast as as oft as you can, all right? And if they ask any question, tell them Dr. Grandison made a recommend. Tell them to talk with take it up with Dr. Grandison because I gave the recommendation and the presentation. All right. All right. So we now make segues into cancer of the womb. Right. So cancer of the womb, it has some risk factors. Basically, everything that they're talking about here this evening, talk about the risk factors and how we're going to screen for them. So risk factors, you have the age. As the age is basically a risk factor for almost everything. As we age, we are more prone to everything and anything, right? Whether it be hypertension, diabetes, all sort of thing, cancer, everything. As we age, we're more prone to them, right? Another risk factor here is obesity, right? As I mentioned before, fat is not just fat. And even though in Jamaica we love our fluffy and we talk about fluffy diva and all sort of thing, right? Being fluffy comes with its risk, right? Both for males and females. And obesity or fluffiness is it increases the risk of cancer of the womb because as I mentioned before, the fat that is there is not just sitting there doing nothing. It is there and it is making hormones. And these hormones, they're stimulating sites all over the body, including the lining of the womb, causing it to grow. And if it is stimulating it, then it can cause it to produce cancer. Right? Cancer of the womb, it's very race is a risk factor. It seems to be race and genetics, you can basically put them together, right? It is common among blacks in genetics. If you have a family history of certain types of um, colorectal cancer and other types of cancer, then there's an increased risk of it. Diabetes as well, because when somebody has diabetes, they have higher level for the most part, and this is particularly true of type 2 diabetes. They have a higher level of insulin than what normal people have. And insulin is a pro-inflammatory um, um, hormone that is found in the body, especially when it is elevated for a long period of time. And so this causes that this stimulates the line of the womb and can result in increase the risk of um, of womb cancer, right? Other cancers as well, right? Increases. There's a risk factor, tamoxifen, which is a hormone that is used, generally speaking, for women who have breast cancer. It helps to decrease the recurrence of breast cancer, but it also can stimulate the growth of the line of the womb and hence increase the risk of womb cancer. Radiation therapy, because if you are exposed to radiation, it damages cells and that can also cause mutation leading to cancer. And diet and nutrition, I'd mentioned before about our diet and how dangerous it can be when we're eating ultra-processed foods, we're not eating properly. These things, they increase our risk. And estrogen, I would have mentioned it as it relates to the fat, the adipose tissue. So, what are some of the symptoms of endometrial cancer or cancer of the womb? Right? So a lot of it is spotting or bleeding or vaginal bleeding between periods. So that's why whenever this is one of the cancer that actually gives a warning, it just doesn't happen like that. It gives a warning. And so women may present with just bleeding, like abnormal vaginal bleeding. Like they know it's not time for the period, but no, they're having some spotting. And they come to us, get checked, do an ultrasound, realize that there's something happening in the womb. We do a biopsy, and then lo and behold, it's a cancer, right? So, and this is especially true for women who are 45 years and older. So whenever I see a patient who is 45 years and older, and she's having spotting, abnormal bleeding, right? Even though it may be perimenopausal bleeding, I still, as in as you approach menopause, the periods start to get irregular. So if I see this happening and the patient is 45 years or older, the first thing I want to rule out is a cancer. Right? Because if it's not a cancer, we have time, we can chill. If it's a cancer, we need to move, we need to get things going because if not, it can have serious consequences. So, not only is there spotting or vaginal bleeding between periods, there can also be changes in the heaviness or length of one's period. So the period can now become much, much heavier. So, flooding and, have to be using maternity pads and you passing huge clots and those things. It could be a sign of cancer. It could be fibroid. It could be other things, but it could also be cancer, right? Especially if the woman has risk factor and if she's in most cases 45 years and most and over, right? And postmenopausal vaginal bleed, right? I think I'd mentioned menopause. In the last presentation I did, and I put out a little warning at the end, right? And so this here, once you've gone into menopause, you should not have any bleeding at all, right? Once you stop seeing a period, if there's any bleeding that comes back, we need to investigate that because that could well be cancer, right? Some women, they may just have low abdominal pain. Some women, they may just be having this watery vaginal discharge. Some may be having blood-tinged discharge. Some women may have pain when they're having sexual intercourse, right? They never used to have pain, and all of a sudden they're having pain. Could be because something is there growing and causing the pain, right? And so that needs to be expected. When it starts to, spread and go to other areas, this is where you start to have the unexpected weight loss, right? Or they might feel something in the belly, like the belly just getting bigger, right? So these basically are like some late signs. Now, I think, right, so as I'd mentioned in the slide before, if your menses stop for a year or more, and this is especially true for those who are perimenopause or menopause at 45 years or more, right? If the period stop for a year or more, and then it comes back, you need to see your doctor urgently, right? Because something could be going wrong. No, we don't really have screening per se. There's not a screening protocol for it. But what we actually do, based on the risk factors that a woman may present with, we do investigation. So if she has a strong history that suggests that it could be a cancer, then we do further investigation, ultrasound, MRI. We can also do, if the line of the womb is thickened, then we do take a sample of the womb as well, send it off so that we can study it under a microscope. All right, ovarian cancer. All right, so we're coming down, right? We have this and then one more to go, and then that's it. So the risk factor for ovaries. So you have every woman, each woman has two ovaries, or should have two ovaries, right? So what are some of the risk factors for ovarian cancer? And this one is one of the ones that is very, it's kind of sinister because generally speaking, once you discover it, is basically, generally speaking, it's too late once it's discovered, right? So this is the one that is very subtle, and the one if you were you probably weren't paying attention for the other one. This is the one that you probably want to make pay attention to because this is the one that is very sinister. It's very it's just flowing under the radar there and just giving some little but it just giving you some little signal, but you're not gonna really interpret it as that. We're going to think it's gas, right? So you have family history of breast cancer, ovarian cancer, that's a risk factor. Genetic mutation as can happen. Hormone replacement therapy, more menstrual cycles. So, for example, women who have not had any children, right, they're at an increased risk of ovarian cancer, right? Because when you get pregnant, you don't ovulate. And there's a theory that when you don't ovulate, then you're not producing any eggs. And you're pregnant for 9 months, for example. So in those 9 months there, you don't see any menses and you don't have any scarring of the ovary, right? So you can just imagine for a woman who has like 5 children, that's basically 45 months, so to speak, right? That she's gone without seeing any periods in total. So that significantly decreases her risk of ovarian cancer, right? And as I had mentioned, increased age is a risk factor for almost all cancer that you can think about, right? And then what decreases it? Removal of the ovaries or fallopian tube. So some women, they might have done a tie-off that decreases the risk of ovarian cancer. Some women do surgery, like they might have a very, very strong family history, and they have completed their childbearing, and they say, Doc, just remove my ovary or remove my fallopian tube, right? And we just do a surgery to just remove it because of the very, very strong family history that the person has, right? So we just do what most times called a subtotal hysterectomy. So we just remove the uterus and the fallopian tubes and ovaries. Right. Childbearing decreases the risk more than the less chances. Breastfeeding as well, there's some weird association between it, but I guess it's more banking on this. So when you're breastfeeding, especially most women, because breastfeeding can be used as a form of contraception because when a woman is breastfeeding, there's a high level of what we call prolactin, and it suppresses ovulation. So while a woman is breastfeeding, for most women or a lot of women, they don't see any periods, right? A lot of them, especially for those who are breastfeeding adequately and appropriately, their periods basically stop. Some women don't see any periods for like 6 months. They're breastfeeding exclusively. There's no formula, nothing like that. If you're not ovulating, then you're not scarring the ovary, and as a result of that, decrease the risk of, breast cancer. I mean, sorry, ovarian cancer. And oral contraceptive use, again, the same thing, because a lot of them, they suppress ovulation, so less scarring. Tubal ligation, as I'd mentioned, some women, they do a tubal ligation, they do a tie-off, because they don't want any further children. Just doing that alone decreases the risk of getting ovarian cancer, right? Now, so this is the slide now that I want you to pay attention to because a lot of time these are some of the symptoms women present with. And it is so, as I say, it is so it's like a camouflage. It simulates other thing. So the patient may present and they tell you, boy, from the other day, I just having this upset stomach and I just a drink it ginger tea and the ginger tea not help, right? And right there, alarm should be going off. This could be ovarian cancer until proven otherwise. Right? I had a very, very close friend of mine who had something similar. She basically was having what we call this, like she was just, having bloated, stomach bloating, like she eating and, the food just not tasting nice and, and she just thought that it was just drinking her ginger tea, drinking, the alusil, the aluminum hydroxide, taking all sort of thing. And, it was when it just started to get worse. I said, no, man, no, I need to go to the doctor. Went to the doctor, did an ultrasound. When you look, it was a big tumor on the ovary, right? And she had to do major surgery to have that sorted out, right? And it was indeed ovarian cancer, right? So it presents with some funny symptoms, upset stomach, you feel full quickly, stomach bloating, frequent urination because it might be pressing against the bladder, pain in the belly button. No, if you have pain, generally speaking, tells us that something is going wrong, that needs to be sorted out. But frequent urination doesn't really say that something is going wrong, right? Neither does feeling full quickly nor upset stomach doesn't really tell us that something, but pain does. So for the most part, women who present with the pain, they normally present a lot earlier, right? But the others who are having those confusing symptoms, they tend to present much later, but by that time, it would have spread to other areas, and sometimes you can't really do much about it at that time. All right, so that is why ovarian cancer is so serious and dangerous of all of these I just presented before. Because with the breast cancer, there is a lump that most women going to feel. For the endometrial cancer, there is some bleeding, right? But for this, it's just upset stomach for the most part, right? Which is just so non-specific, right? So again, there is no protocol for screening or detection of ovarian cancer. But again, for women who have a high risk, like they might have the BRCA1 and 2 gene in their family, have a high risk, have a high family incidence of breast cancer, prostate cancer, pancreatic cancer, right? Then these women, we can basically zone in on them and start doing routine ultrasounds early just to see if there's any abnormality in the ovary. And then based on it, now we can do further testing like the CA125 and other tests to see if it is that there is some evidence of ovarian cancer. And finally, now touching on cervical cancer, it is, as I had mentioned before, one of the worst cancers that we're experiencing in Jamaica. And it's the one that is one of the most preventable cancer because it doesn't, while it cannot really stop, ovarian and endometrial and breast, you can actually stop cervical cancer because it gives warning before it reaches cancer, right? So some of the risk factors for it are the human papilloma virus. Most women who have heard about this, right? Human papilloma virus, HPV virus. It is one of the leading causes, especially the subtype 16 and 18, amongst others, right? The sexual history, women who have started having sex at an early age at an increased risk, and hence why the vaccine is aimed at girls, young girls, before when they're sexually naive, starting from about ages 9 to 12, when they haven't had any sexual intercourse, because after that, when they start to get exposed to sex, then the virus, it takes about 10 to 20 years to cause all the changes that will result in cancer. So if she's exposed, if she started having sex when she's 14, if she's not going and getting checked or anything like that, by the time she is 34, she could actually have full-blown cervical cancer, right? So because it takes about 15 to 20 years. So if she starts at 15, 14, then by the time she is, say 30, 35, she could have full-blown cervical cancer. Having smoking is a risk factor as well, right? As you know, smoking alters your immune system and how your body reacts. Having a weakened immune system, right? So one of this is like with HIV patients, we have to screen them basically on a yearly basis because their immune system is weak or weaker, and as a result of that, they have an increased risk of cervical cancer, chlamydia infection, right? So these are sexually transmitted infection. It's also been said that it's associated or can be associated with higher transmission of the HPV virus, right? Because all of them is like a cocktail of disease, right? The HPV working with the chlamydia and the gonorrhea, right? So they're all brothers and sisters and they come at once, right? In a lot of cases, right? So women who are at high risk, they are having sexual exposure. They at an early age, for example, exposed to all of these, and clearly it increases the risk of them getting the HPV virus and hence cervical cancer. Long-term use of oral contraceptive. This one is kind of, the, the evidence out there is not so strong, but there is some amount of evidence from small studies suggesting that the long-term use of oral contraceptive can increase your risk of cervical cancer. Having multiple full-term pregnancy. So this talking about and so this is basically talking about women who have had and this in this particular context, we're talking about women who have multiple children from many different partners, right? So that increases rate. So more sexual partners they have, the greater the chance, right? And the young age at first full-term pregnancy, right? So as we know, the younger girls, they're at an increased risk because the body isn't fully developed as such, and as a result of that, right, they're at an increased risk. Economic status, as we know, women who are less fortunate in terms of their social and educational standards, they will be at an increased risk of almost anything that you can think about, right? A diet that is low in fruit and vegetables, right? Those as well. As I've mentioned before, diet is an important thing. Now, what are some of the symptoms of cervical cancer? It can be abnormal vaginal bleeding, right? So this is the most common presentation of it. Bleeding in between periods, right? Or bleeding after menopause, right? So this can happen as well. Abnormal vaginal discharge, excessive or smelly, or blood mix. So I've seen this, and so here's what now. And you know, sometimes sometimes you just have to be. So I might have somebody this is a true case now. A patient who had gone to multiple different persons, right? She so what she said, she just went to the doctor, said that she's having a vaginal discharge, and said, Doc, can you just prescribe something for me? I'm having a vaginal discharge. Doctor said, okay, no problem, man. Just write up something and give it to her, right? But this vaginal discharge continued, so she go to another doctor, said, Doctor, I did got to get an insert the last time, but it never worked. I still having the discharge. You can just write one for me. And doctor said, okay, no problem. I just write up a prescription and give it to her, right? And she was just floating around, floating around, floating around until she came to us and was examined, right? And we say, okay, let us examine you. Did anybody at any time examine you? No. We just wrote prescription because I told them I had this child. I said, okay, so we are not just going to write a prescription for you. We're actually going to examine you. And when we examined her past the speculum, lo and behold, it was actually cervical cancer. So she was getting inserts all along, thinking that this was just a yeast infection or whatever it is, but it was actually cervical cancer, right? So I want to encourage you, ladies, as much as you think you might know your body, when you go to the doctor, do not tell the doctor that you're having a vaginal discharge and you just need to prescribe something, right? And if he's just going to prescribe something, say, Doc, I'd rather if you have a look. Just take a look just to make sure that everything is fine because cervical cancer can present as abnormal vaginal discharge, just having this discharge, you're not sure where it's coming from. I think it's some yeast or bacterial vaginosis, you know. And so I want to encourage you when you go to your doctor, just make sure that you're properly examined wherever it is that you go, right? You're having a discharge, that then pass a speculum and look, right? It takes nothing out of anybody to just take a speculum and just look, right? And if you see something, then great. If you don't see anything, it's fine. Now, bleeding after, so we call this postcoital bleeding. Sorry if the R is left out of it, right? So this is bleeding. A lot of women, right? One of the first thing that they present with, it tells the doc, every time I have sex, I bleed, you know? I say, okay. And then when you look, it might not be cancer itself, but it might be pre-cancer. The cervix is so inflamed, right? And then we can, we can find out. And then really, this is when it reaches severe stage. You have severe pain, leg swelling, leakage of urine, and passes to the vagina. That is when that start to spread. That's like stage 3 and stage 4 cervical cancer, when it's gone really, really bad, right? So what do? We start screening. Here in Jamaica, we start screening at age 21, right? Initially, earlier on, it was like at age 26, but we have started following the different guidelines and start at age 21, and we do it every 3 years, right? Now, because of the high incidence in our population, generally speaking, we normally recommend that, there's nothing wrong with doing it every year, right? So that you do not miss anything, right? And so that is also the pap smear. Then now there is what we call the HPV testing, which we can, for most women, it can begin at round about age 30 according to some protocols, right? So you do both so we call it co-testing, do the pap smear and the co-test and the HPV test. And if it's negative, then they don't have to come back until another 5 years or so, right? And this continues up until age 65. We continue screening or until we get 3 negative consecutive pap smears, right? In some women who probably had a previous abnormal pap smear. And what we have been seeing in our population as well, and that's why sometimes we even continue to screen beyond age 65, is that there are women who are presenting to private offices and the hospital who are over the age of 65, who have previously had normal pap smear, who turn up having cervical cancer, right? So that's why we generally speaking don't just limit it and say, all right, you reach 65, everything is fine, you can stop, right? We continue to screen for the most part as well. Probably not every year, but every 3, every 5 year, to ensure that they are covered. Right. So if you want to reduce your risk of cancer as we come to a close, do not smoke or use tobacco in any of its form. As you notice, smoking, it alters the immune system, right? Ensure that you have a healthy diet. Healthy diet meaning that you're eating the right stuff, right? The more natural, the greener your plate look, or the more colorful your plate look, then it means that you're eating properly. I know that we have a lot of food that is filled with pesticide and all sort of thing, but if we can, as much as possible, even grow our own things, it might be good. And sometimes it is that we can't really avoid, so we just eat what we can eat, in terms of ensure that we eat it, and just ask the Lord to just bless the food, right? When we're asking the Lord to bless the food that we're eating, we're not just saying it, we're not just repeating it, actually asking Him to bless the food. We're not just saying it for saying its sake. We're asking Him to bless the food because it might not have all the things that we need, but in asking His blessing, He can miraculously add what needs to be added and remove what needs to be removed from the food that could be danger and toxic to our bodies. So If we can't grow our own things, then we get the healthy food that might have been used with chemicals. But pray and ask the Lord to bless it so that it can do our bodies good and not harm. Right? And then get vaccinated, especially HPV vaccine for the young girls, right? In 9 to 12 thereabouts. Avoid too much exposure to the sun as this increases the risk of skin cancer, right? Reduce indoor and outdoor air pollution. So you want to live in an area, an atmosphere, right, where you're breathing clean air. Be physically active as much as possible. Limit alcohol intake, and then try and get screened as often as possible. All right. So, with that being said, thank you so much, and God bless you.
Amen.
Oh,
Amen. My God, what a mouthful. Queens and kings. We cannot, I must confess that we cannot pay Dr. Grandison for this. This is more than a consultation this evening. And you know that consultation fee is high. Come on, what a comprehensive presentation from Dr. Grandison himself. My God, so much. I was just glued. I had a lot of questions I perhaps could type in the chat, but I was just so glued to my device because I just never wanted to miss out on anything that he presented on this evening. And so, Dr. Grandison, in the interest of time, I am just going to open this segment now for question and answers. And let me tell you, if you have any questions in your mind, do not leave because you can't pay for this. As a matter of fact, I'm going to be saying something to the latter end of this evening's meeting. But I want to say to you, here is the time that we will take the questions, and as much as we can put in, we're not going to exhaust Doc, but we are going to see how many of the questions that we can actually take on this evening. So here is the opportunity now, kings and queens, to post your questions in the chat. We have the raise hand feature. You can use that. We will ask you to unmute your microphone and to interact with us at this time. Let me tell you, if you take too long to start ask questions, we're just going to have to pronounce a benediction. So come along and let us just get this segment out of the way. So while they are, things are marinating because it was a whole lot to chew on this evening. This is so comprehensive this evening. Let me just pull up a very quick one here, Doc, as it relates to breast cancer. So you spoke about finding, feeling lumps and so on in the breast. Is it that you can actually have breast cancer without a lump being evident in the breast?
yes, right. So there can actually be breast cancer without a lump. And most likely so in the very, very early stages before it becomes what we call palpable, before you can feel it, right? Because it's not until it becomes big enough that you start to feel it as a lump. But before, sometimes it is a sign, it is the size of a grain of sand, right? Or the size of a grain of rice. So it being that small, you won't be able to feel it. But if a mammogram is done, it definitely will pick it up if it's a sign of a grain of sand or if it's the size of a grain of rice. And so this is where the mammogram is very important because it actually helps to pick it up. And I always say to people, when would you like to detect it? When it is the size of a grain of rice or the size of an orange? Because you definitely want to pick it up when it's the size of a grain of rice, because then it means that it has not had any significant chance to grow nor do anything, as opposed to, where it gets, when it gets very big, right? So it's not always palpable, especially in the initial phases of it. right? And that is why we encourage having this screening being done. And because breast cancer, even though it can present at a very young age, it tends to present at an increasing at an increasing rate from the fourth decade of life onwards. So from the 40s, 50s, 60s, 70s, that's when you find the highest incidence of breast cancer, right? Because I remember I was called to visit, check a patient at a nursing home. And when I went and examined, there was a lump in the breast, right? And she was in her 80s, right? And she never had that lump before, but because she's at the nursing home, not moving around and things like that, So I'm just saying this to say that even, when the person is well out there, 60 odd, 70 odd, they're still at risk because this is a time that it actually starts to thrive and flourish, as opposed to when a person is a teenager or in their 20s, 30s. Right? It's more so in the latter half of the fourth decade of life, fifth decade, six, seven, that you start to see an increased incidence.
Right. All right. So thank you so much. Just a follow-up to that though. Women sometimes, when we get to the age when we need to really start doing the mammogram,
Mhm.
women have, all of these hang-ups about it painful and so on. Is there an alternative? No, or it is just the same measures that we would have been used to for the mammogram. Is there any alternatives?
Yes, so so most of the centers in Jamaica that do it, especially like that I'm aware of, they use the old one where you put the breast and it press. So a lot of women there is this pain that is associated with it. But I think in Kingston, there's a place that does a new form of it. It's the same thing, but it's a little bit more, it's not that painful, right? And it's more expensive though, right?
Can
And
imagine.
right, it's more expensive, but it's good. So a lot of women they flock to that one. I can't remember the name of the place in Kingston, but I can find it out and I
When
could
you
give
do
you
that, please to relay the information so I can
right.
pass it on.
Yes,
But
yes. There's
the
a place,
females
I
here.
think
So
it's on
those
Ripon Road in Kingston, but I can't remember the name of it or who operates it, but I know that it's there because it was a patient who told me about it, you know. Outside of the mammogram though, and so the mammogram now, for the most part, it's like the the it's relatively cheap, 7,000 to $10,000 in most places that you go to do it. An alternative would be to you do an MRI, but the MRI is going to be $50,000, $60,000. And can you just imagine doing that yearly, right? And this is not covered by a health card, right? So that's a lot of money compared to paying $7,500 to $10,000. So it is much cheaper than the MRI, and it can give you the same information that the MRI would have given you. So technically speaking, you can say that it is just as good as the MRI, right? For a cheaper price. It's not quite an MRI. It can't compare to, because clearly the MRI would be a little bit superior to it. But for economical reason, sorry, it's easier to just do the mammogram, right? So
All right, so we're picking up a couple of questions. You can use the raise hand feature as well. Here's a question from Derek and Sydney Graham. Can pain in the breast to the back be an indication of cancer?
say that again, can pain in the breast,
To the back be an indication of cancer?
as in at the back of the breast, as in deep in the breast. All right, so I think I'll pain in the breast to the back. Okay, so I guess if they're saying as in deep in the breast, they're feeling some pain. Yeah, I mean, it could be, right? It might not necessarily be cancer, but it's something worth checking out because, as I mentioned, pain is one of the earliest signs that you get that something has gone wrong, is going wrong, or about to go wrong. So pain is the first sign. So, we generally speaking should not ignore pain. You want to act on it. You want to check it out, follow it up to see if there is something worthwhile pursuing, because there could be.
Okay, thank you so much, Doc. And I don't know why we're quiet around here. I know this is not a topic that we readily want to talk about, we readily want to hear about. It's just a reality of the world that we are living in. Let me see if there are any other questions here. I saw a question about where in Maypenny office is. We will give that information in a little while because
Right.
I'm going to make an appeal,
Mhm.
especially for those of us who are living in Clarendon, because what Doc said earlier about Clarendon having the highest rate of cervical cancer don't sound good at all. And so, on the other end, I will make an appeal to all of us, but especially those of us who are living in Clarendon and we have not been doing our routine examination. All right, from Dan. Queen Dan is saying, which is better to detect breast cancer, whether right, the mammogram or ultrasound? I believe Doc would have spoken to that one, but
Mhm.
ultrasound was not mentioned when you responded to that question, Doc.
Right.
Somebody was asking.
So the ultrasound is not a bad test. The ultrasound can pick up certain abnormalities, can tell us that there's a cyst or there's a lump. Because sometimes one of the first things that you send a patient to do, if I'm examining a patient and I feel like I say for example, it's a younger patient, she's in her 30s or 20s and I feel a lump, I don't send her to do a mammogram, I send her to do an ultrasound, right? Um, to see, because of how dense the breast of a 20-year-old might be, right? It might be the mammogram might not pick it up as quickly. So this ultrasound may perform superior to it, especially if a lump is felt. And then if a lump is felt, once it's picked up physically and the ultrasound confirms it, then the next thing I just send the person to see the surgeon, the general surgeon, to actually have surgery done, right? To remove the cyst or the lump. Now, if the patient is in her, late 40s, 50s, and I feel a lump, then what I'm going to send her to do is I can actually send her to do an ultrasound, right? But what I'll do in this case would be um, uh, the mammogram, and the mammogram, based on certain features, right, will give us whether there's a high chance. It scores it in a thing that is called BIRADS. BIRADS 1, 2, 3, 4, and 5, right? Where 3, 4, and 5 are the ones that, you have concern that this might be cancerous, right? So the ultrasound doesn't necessarily give that scoring, but the mammogram can give that scoring, and it's called BIRADS score, right? And that can help. That's a useful information. Even though the ultrasound can probably give you the information, but the mammogram is what we generally use for that. So, as I mentioned, if a patient is young, in her 20s, early 30s, I tend to, most physicians would send them to do an ultrasound of the breast or probably an MRI of the breast, right? As opposed to a mammogram if she is, in her late 40s, 50s and above, and there's a lump that's in the breast, then more than likely the go-to is going to be a mammogram.